Hello, everyone. I am Livia Edegger, the Deputy Director of the International Society of Substance Use Professionals. I'm here with my colleague, Jeff Lee, ISSUP Senior Consultant. It is our pleasure to welcome you to our first virtual and regional ISSUP conference. We have held major conferences in the past in Thailand, in Brazil, Mexico, Kenya, and Austria, but this is our first regional conference organized with our national chapter in South Africa and our first virtual conference. On behalf of ISSUP, I would like to particularly thank our colleagues from ISSUP South Africa for their collaboration and all of our partner organizations for their dedication and hard work in planning this event. I would like to thank our partners at the African Union Commission, our partners at the South African National Council on Alcoholism and Drug Dependence, also known as SANCA, our partners at the Department of Social Development of the Republic of South Africa, our partners at the US Department of State's Bureau of International Narcotics and Law Enforcement Affairs, also known as INL, and our partners at the Organization of American States Inter-American Drug Abuse Control Commission, CICAD. I would also like to thank all of our opening ceremony speakers and our panelists for presenting at today's first session. Special thanks also go to my colleagues at ISSUP who have helped to put together this fantastic event. I would like to especially thank my colleague Jeff Lee for offering his expertise in the field. I would also like to thank Diana Crossan for keeping us organized and on top of the planning, and Michael Broby, our regional and national chapter coordinator for Africa. To all of you, thank you very much for participating. I would like to encourage you to become a member of ISSUP if you haven't already, so that you can become part of our group of professionals working in drug demand reduction, and so that you can access the wealth of information available on our website and share your skills and your knowledge, and in that way also support other ISSUP members around the world. You can apply for membership on our website at www.issup.net, www.issup.net. The good thing is that membership is free. I would also like to invite you to become a member of your national chapter, if there is one in your country, so that you can receive up-to-date information on the activities organized in your country and in your region. There are now more than 13,000 professionals that are part of our network, and we have established national chapters in 20 countries, including 5 chapters in Africa. So we have a chapter in South Africa, in Kenya, and in Uganda, in Nigeria, and in Togo, and we have 1 chapter that's on its way in Botswana. It is really an honor and a pleasure to work with our national chapters, and I would really like to thank all of them for their commitment and for their hard work. Over the course of the next 3 months, our virtual plenaries will provide a range of national and international experts in the field of drug demand reduction. They'll be speaking on a variety of key topics in prevention, treatment, and epidemiology. And we will also be featuring a special session that will address the role of traditional leaders and health practitioners and the legislators' role in drug demand reduction. There will also be, at the end of it in November, on the 10th of November, there will be a final question and answer session where we will be able to review important issues that have been raised and to consider next steps from the conference that we hope will then translate into actions. And also, if you have any questions today or throughout the 2.5 months that we'll be together, we have created a network that's an online forum on our website for this conference. So if you are an ISSUP member, you will have automatic access to that network. For those of you who are not yet ISSUP members, we have sent you, and you should have received, we've sent you an email invitation to become a member. And after having signed up as a member, you will be automatically added to that network, and you can access it through our website. Talking a bit about today and the structure, so we will kick off the first conference session today with the opening ceremony, in which our esteemed speakers will provide the welcome remarks, and then we will move on to the presentations, right? And the presentations today will really set the scene for the challenges ahead. And at the end, we will have time for a short Q&A session. So this is very important. If you have any questions, please do send us your questions during the presentations. You can do that through the chat function on the GoToWebinar control panel. So please do send us your questions. And there is simultaneous translation offered into Spanish, Portuguese, French, and Arabic. So you can find the link for that. You will have to click on a link to access the simultaneous translation, and the link is in the chat function as well. And you can send us your questions in those languages because we have translators here helping us with translating them into English as well. One thing that I would like to mention is that we hope that we will not run into any connection issues, but we hope that you do understand that there might be technical problems. It's just the nature of holding a virtual conference, of holding live sessions, and we hope that you understand that it is not all under our control. For those of you who want to rewatch our sessions, they will be shared, and the recordings will be on our website. So we will, in the coming days, we will upload the recording of this session, and you will also receive an email, a follow-up email, including the link to the recording. So we will now start the official opening ceremony, and I would like to ask our esteemed speakers to please turn on their cameras. It is my honor to introduce Roger Weimann, who is the president of ISSUP South Africa and the director of the South African National Council on Alcoholism and Drug Dependence, SANCA Eastern Cape. It's really a pleasure for me to work with Roger and this ISSUP South Africa team, and we at ISSUP Global are really very grateful for all their support and dedication, and also for their collaboration on co-organizing this event. So thank you very much, Roger, for being with us today, and over to you.
Thank you, Livia. Her Excellency Amira Elfadil, the Honourable Deputy Minister of Social Development, Hendrietta Bogopane-Zulu, the Honourable Deputy Minister of Basic Education, Regina Chloé, Ambassador Adam Namm, INL Branch Chief Brian Morales, ISSUP Global Chief Executive Joanna Travis-Roberts, our invited speakers, panelists, and all of you who have joined us today, I would like to extend a warm welcome to you all. Kuni makawe, nakuni makawe kazi, ase Africa, diabolisa. Heroes and heroines of Africa, I greet you. Today is indeed an exciting and momentous occasion for South Africa, and indeed the whole of the African continent. As ISSUP South Africa, together with the South African National Council on Alcohol and Drug Dependence, otherwise known as SANCA, we are immensely proud to be co-hosts of the first virtual African conference on drug demand reduction. Never before have we seen so many international, continental, and local partners coming together to unite in a single cause, to be able to share knowledge, best practice, and standards with the drug demand reduction professional community from all over the African continent. This conference will indelibly link Africa and the drug demand reduction work being done throughout the diverse countries and cultures to the international drug demand reduction profession. It is an opportunity to become part of the solution, to collectively take action to intensify substance use prevention and treatment efforts. This series, presented by experts in the field, provides a platform to deliberate and share and ultimately support an integrated, holistic approach for Africa, by Africa, as well as an opportunity for Africa to share our best practice with the world. The future of our continent is being clouded by the substance use pandemic, primarily because it is the youth who are most at risk. The COVID pandemic has highlighted the fact that substance use and the associated disorders can no longer be hidden. More and more people from all corners of society are waking up to the impact that substance use disorder has on the very fabric of individual, community, and societal life. September is Heritage Month in South Africa, and the launch of this conference is evidence that we, as Africans, and indeed global citizens, can come together to ignite a movement that can bring about positive progress in the field of drug demand reduction. We are honored that so many partners from around the world have placed their support and indeed offered their involvement in this auspicious occasion. A particular vote of thanks must go to the African Union Commission, the Government of South Africa, ISSUP Global, SANCA, CICAD, and the INL for their contributions to the implementation of this conference. ISSUP South Africa hopes that all those delegates registered for the virtual conference will find benefit in the sessions planned, and we look forward to welcoming you as new members of our chapter. Umtu, Ngumtu, Gabantu. A person is a person through other people. Thank you and welcome.
Roger, thank you so much for those opening words. A real challenge, but a real endorsement of what we're trying to do together. Good afternoon, ladies, gentlemen, honored guests, esteemed colleagues. Forgive us if we don't go through all the titles so knowledgeably as Roger did, and forgive us too in this introduction if we don't give the full biography of such a group of people, which will take at least an hour to go through all that you have done between you to help the cause of drug demand reduction and to build the international effort to address this issue together. So I'm just going to introduce you in your titles to say thank you for being with us. It's a pleasure and honor to be part of this group. And in particular, to actually have the privilege to introduce my friend and colleague, Joanna Travis Roberts, who is now my boss and who has done so much to help me as a friend and colleague and has done so much to put ISSUP further on the road to addressing this cause and to make a contribution internationally to drug demand reduction in the world. So thank you and welcome, Joanna. It would take me too long to say all I could say, but it's good to see you and introduce you.
Thank you, Jeff. That's a very warm welcome, and I would just like to repeat that and extend that warm welcome to our esteemed dignitaries, our officials, speakers, colleagues, and all of you that are listening to the session today. ISSUP is really very privileged to be part of such a landmark event that we are kicking off today, and it really is my pleasure to be able to speak to open something like this, which has taken so much hard work, collaboration and effort on multiple people's part to put this together. But I think we all are doing it because it's so important, and I just want to echo the reasons that Roger put so eloquently to us all, that this really is, there's such a need, such a valuable platform that we have to be able to communicate with you all, and we hope that we make the most of it over the next few weeks and that you all learn from these sessions that we're holding. ISSUP, as many of you know, is a membership organisation. We currently have 13,186 members, and we're really here to build and support anybody who is working around the world to undertake prevention, treatment and recovery support work. Our vision is to have that workforce be connected, trained, knowledgeable and effective, and to be undertaking and promoting high quality, evidence-based and ethical substance use prevention, treatment and recovery support. So the way that we do that, the way that we try and bring this workforce together and keep you all informed is three ways. We have digital, which is via our website, our social media, our email communications, things like this, obviously. And that platform has become vital in recent months as we've all had to switch to this virtual world. Our second pillar is our national chapters. We're very proud to have representative from 20 different national chapter countries, and on a day like this, it's very special to us to really see how effective those national chapters are when we have ISSUP South Africa bringing this conference together and leading it. And we have a series of events which have taken place in person and are now being prioritised in online events, where we have a range of webinars, conferences such as this, which is our first virtual conference. And in these 3 ways, we really hope that we can deliver our mission. As I say, today is a great opportunity to bring together all 3 elements of our work and to be very proud of that collaboration between ISSUP South Africa, ourselves, the US Department of State and INL, African Union Commission, the Department of Social Development from the Republic of South Africa, SANCA, and of course OAS CICAD. And thank you to all of you for joining us for this. But I would like to extend my thanks to the ISSUP team led by Livia, the staff from each of our partners for all the efforts that they have made to bring this together. As we say, it really is no mean feat. So thank you for having us. Enjoy the session, and I look forward to learning together with you over the next few weeks.
Thank you very much, Joanna. It is now my honor to introduce our next speaker, Brian Morales, who is the Branch Chief of Counternarcotics at the Office of Global Programs and Policies at the US Department of State's Bureau of International Narcotics and Law Enforcement Affairs, otherwise known as INL. Thank you very much, Brian, for all your help and support, and thank you very much for being with us today. The virtual floor is yours.
Thank you very much, Livia. Dear esteemed guests and colleagues, good morning from Washington, D.C. in the United States. We're all excited to be here. We were all excited to be in Johannesburg for this conference, and we were actually worried that this pandemic would slow the progress that has been made on drug prevention and treatment in Africa. But today we feel we are with the organizers in South Africa, in Joburg, and with all of you, wherever you may be around the world. I'm happy to say that that the pandemic has not dampened our enthusiasm and spirit for this conference moving forward. And this morning, I want to highlight 3 main points. First, this virtual conference on Africa is possible because of some truly remarkable collaboration by the individuals and organizations that you will hear from today. They also deserve great credit for reaching a much larger audience and in accomplishing our main goal, which is to support the practitioner in the field and the millions who need help with drug use. The African Union Commission has worked to bring member states, partners, and experts to bear on the challenges of drug use. African member states, such as South Africa, have demonstrated strong commitment and skill in addressing this issue. The International Society of Substance Use Professionals is now a recognized home for drug demand reduction practitioners. Training, sharing of best practices, and support is available through them during this time of crisis. Partner organizations, especially in this case, the national chapter of ISSUP South Africa, led by SANCA, have been essential in helping those in need. They offer a unique role to provide services and guide policy. The International Consortium of Universities for Drug Demand Reduction, or ICU DDR, has brought the enormous intellectual power of the academic world to conduct research and to build the next generation of skilled professionals in the prevention and treatment fields. And other organizations and regional partners, especially the United Nations Office on Drugs and Crime, the World Health Organization, and the Organization of American States, have been exceptional partners in this effort. My second point is to highlight the great progress that Africa has made in strengthening drug demand reduction. Africa has a remarkable record of achievement in this field. The African Union has played a crucial role bringing the continent together and contributing to global efforts to tackle addiction. For the past 5 years, the African Union and African countries have worked to create epidemiological networks to improve policy development and expand treatment and prevention services across Africa. This has also led to the creation of the Pan-African Epidemiology Network on Drug Use, or PAENDU, with its first continent-wide report on drug use in Africa published in July 2019. Another priority of the Plan of Action on Drug Control has been to increase the number of trained practitioners in drug treatment and prevention. Many African countries have worked with the Colombo Plan to substantially improve their capacity for drug treatment using the Universal Treatment Curriculum and the Universal Prevention Curriculum. To date, 21 African countries have engaged in training of over 2,500 national trainers. Master trainers from Africa are also sharing their knowledge and training with others throughout the world. There are currently 5 ISSUP chapters in Africa, as we heard, delivering knowledge and systems for evidence-based prevention, treatment, and recovery support at national levels. And Africa has been a regional leader in engaging the talents of its universities in drug prevention and treatment. Over 60 universities are members of ICU-DDR. Africa has also established a strong continent-wide structure to expand further. Finally, based on our discussions with our colleagues in Africa and globally, here are some ideas for our future work together. By far, the most important is to quickly make available online as many of the training programs we support, particularly the Universal Treatment Curriculum and the Universal Prevention Curriculum. We're working very hard on this. We hope to have most of the main courses available early next year. We're very excited that this online transition will greatly expand access to this material. Another area is to establish national quality standard systems with inspection and monitoring forums for governments to consider. We are also looking forward to expand our research and data collection efforts to disseminate best practices and scientific studies that are coming out on addiction. Finally, there's interest in credentialing the professionals for the skills they have learned. It is very important to validate and recognize their knowledge and skills. Let me conclude by again thanking the many dedicated individuals and organizations that have worked to bring about this important event. I extend my best wishes for a successful conference over the weeks ahead. Thank you all very much.
Thank you, Brian. Again, so much could be said about the contribution you've made to getting ISSUP to this stage, and we thank you for your continued work. Our next speaker, I'm fortunate to have had a little bit of knowledge and experience of Ambassador Namm and his contribution to the field of drug demand reduction and his work at CICAD. But as I say, time prevents me from getting into that. So I would just like to introduce and thank Ambassador Adam Namm, Executive Secretary of the Inter-American Drug Abuse Control Commission, known as CICAD, an organization of the American States, OAS. Ambassador, thank you.
Thank you, Jeff. It's a pleasure to be with all of you here in Washington. Good morning to those on this side of the Atlantic. Good afternoon to those on the other side. It is an honor. I hope all of you, your families, and your colleagues are well. I serve as Executive Secretary of the Inter-American Drug Abuse Control Commission, part of the Organization of American States, which is headquartered here in Washington. Many of you know the commission by its Spanish language acronym CICAD. Let me start by thanking the African Union Commission, the National Council on Alcoholism and Drug Dependence of South Africa, the Department of Social Development of the Republic of South Africa, ISSUP Global, ISSUP South Africa, and the U.S. Department of State's Bureau of International Narcotics Affairs and Law Enforcement. Just a few words on who we are. CICAD is the consultative and advisory body of the OAS on drug issues. Since 1986, CICAD has served as a forum for OAS member states to discuss and find solutions to the drug problem, and provides countries with technical assistance to increase their capacities to counter the harmful impact of drug use. We assist member states in strengthening their drug policies by conducting in-depth research and evaluation regarding drug-related issues and emerging trends, and by providing effective technical assistance and specialized training focused on capacity building. CICAD focuses on the reduction of illicit drug consumption, prevention of initial use of drugs, early intervention, and addressing the negative health and social consequences of dependency through treatment, rehabilitation, and aftercare programs. International cooperation is a valuable tool to effectively address the global drug problem. I'm therefore delighted that CICAD is part of this event, aimed at strengthening international collaboration and identifying best practices, as well as exchanging information among experts. It's essential to continue to seek further areas of partnership, and I'm so pleased we have a regular platform to promote an intercontinental dialogue on demand reduction. CICAD has been part of the African, Asian, Latin American, and Caribbean dialogue since participating in the Global ISSUP conference in Nairobi, Kenya in 2018. During that first dialogue, which my number 2 CICAD Assistant Executive Secretary Angela Crowdy attended, participating member states agreed to continue seeking further areas of collaboration and consider the establishment of a joint working group between CICAD and the African Union. CICAD hosted the second dialogue in Cartagena, Colombia, a year later, last year. And last October, we presented on the implementation of national drug demand reduction initiatives in Latin America and the Caribbean at the Continental Consultation for Drug Demand Reduction Focal Points in Africa, held in Port Louis, Mauritius. As mentioned, CICAD's programming includes conducting in-depth research and evaluation regarding drug-related issues and emerging trends, which are key in providing OAS member states with data necessary for designing effective, evidence-based drug policies. CICAD's Inter-American Observatory on Drugs, known by its Spanish language acronym OID, develops standardized protocols for the collection of data and the implementation of drug-related studies. In addition, it promotes strong national drug observatories in the Western Hemisphere that use standardized data collection methods, as well as the establishment of drug information networks and early warning systems to improve drug-related data collection, analysis, and dissemination. Last year, CICAD published the Report on Drug Use in the Americas 2019, which analyzes drug use data in OAS member states. The report features information on the most widely used drugs across the Americas and highlights emerging issues of interest to policymakers and to the public. Marya Hynes, who leads the OID, will shortly provide you with highlights from that report. And let me also say I'm pleased that Jimena Kalowski, our demand reduction unit chief, is online attending this event as well. To close, I want to emphasize the importance of the conference's, this conference's 3 main pillars: prevention, treatment, and epidemiology. Given the impact of substance misuse on public health and the increased risk for long-term medical consequences, it's critical to prevent substance misuse from starting and to identify those who have already begun to misuse substances and intervene early. Evidence-based prevention and interventions carried out before the need for treatment are critical because they can delay early use and stop the progression from use to problematic use, all of which are associated with costly individual, social, and public health consequences. Regarding treatment, to be effective, it must address the individual's drug abuse and any associated problems, such as medical, psychological, and social. It must also be appropriate to the individual's age, gender, ethnicity, and culture. Finally, for scientific research and analysis to take place, it's essential to establish and strengthen existing national observatories on drugs for the development of national drug information systems. It's also crucial for us to work together to strengthen the monitoring and evaluation of drug programs and interventions through evidence-based analysis. I look forward to continued valuable dialogue and collaboration, and thank you all very much for your attention.
Thank you very much, Ambassador Namm. It is our pleasure to work with you and to work with CICAD in the Americas. And also I would like to thank you and your team again for your support in this event as well in Africa. It is our honor to also have with us today Ms. Hendrietta Bogopane-Zulu, who is the Deputy Minister of the Department of Social Development of the Republic of South Africa. Thank you very much for being with us today.
Thank you very much, and allow me to extend South Africa's hospitality. Even if it's digital, we remain very hospitable and would have loved to have you in Johannesburg, but nonetheless, we're still grateful that you are still in South Africa. So allow me to welcome you to South Africa. And good morning to the ones on the other side. And for us who are about to go to bed, good afternoon, good day, and good evening. Let me acknowledge all of the protocols that has been laid and acknowledge all your excellencies, distinguished guests and gentlemen. Let me also acknowledge my colleague, the Deputy Minister of Basic Education, for without them participating, we're not going to be able to actually achieve a drug-free South Africa, because they are the custodians of children, even though we give them the children from our side when they turn 5, but the biggest time they spend in basic education. And I think this conference is all about what is it that we can do differently to actually begin to make the demand reduction, the different elements, but how do we strengthen our own government in terms of the supply of the relevant professionals. Firstly, we'd like to thank the Colombo Plan, because we are one of the beneficiaries, and we actually are very excited because a lot of our services in the department in terms of substance use have been improved, as well as our policy outlook. So that has assisted us to actually make sure that we are able to also be in line not only with our drug master plan that introduces a lot of innovation 2020 to 2025, and we can also say that our drug master plan is based squarely also on the Africa Common Position and the Africa Drug Master Plan. For South Africa, I think there are a few things that I would like us, as we kickstart the conference, acknowledging and thanking the organizers for actually remembering that we are Africans, and a lot of our work and a lot of who we turn to in different times of need are our traditional leaders, more than it is our health professionals and our traditional healers as well. So that brings in most needed intervention, because I'm likely to actually talk to my traditional healer at the hospital. Let me also say the Department of Social Development in South Africa is the custodian of the drug policy in rehabilitation, prevention, and our security as well. But what we actually enjoy is rehabilitation, drug policy, it puts the drug business and also to be human rights, but the inherent identity of drugs is undermined. Whether it is evidence-based, as we always say, some scientific, ethical, what we want to say throughout the seminar is the right of the user must never be lost. It must never be replaced by science. It must never be undermined by whatever ethics. It must never also be diluted in terms of what their reality is and how they made drugs, at what age, and what kind of drugs. For us as South Africa, there's two things. The first one is geography did not do us a lot of favors. Our geographic location makes us easy in terms of the trafficking of drugs into Africa, but not only drugs, but actually people as well. So we find ourselves as a government to actually be spending a lot of money, not only in terms of prevention to raise advocacy and awareness, but also prevention in terms of having the specialized areas to be able to fight the trafficking of drugs in and out of South Africa. We have a lot of harbors, but also a lot of points of entry that actually makes supplying our neighboring countries and Africa as a whole a lot easier. But I need to say, with the reopening of our specialized narcotics drugs unit, that is beginning to actually give us the impact that we need. Let me also say that I think what is important that I'd like us to think about as we go through the 6 sessions, which we will be honored to work through all we can to be part of, is the impact of drugs on business. And so that when we develop strategies like and use thereof has but also abuse instrument of them accessing drugs at a very early age. For us as a country, we're facing the realities as the department that's responsible for rehabilitation, where we are beginning to actually have well-established treatment protocols for children who are using drugs, with our youngest addict at 3 years old, and having access to the drugs, not in the street, not at an ECT, but from their own parents, in the family and in the home. So it begins to bring us back to saying, as we develop the mechanisms and the dialogues that are going to happen, to what extent are we able to actually provide evidence, scientific, ethical, and all of the right language that we are talking about to families, because a lot of the spaces in families are actually not regulated by government. We support and we are the custodians of the policy on families, but I can assure you that what happens in the actual home, we get to be involved at the end when the child is already addicted. And the conference will assist us as we go through all of that. But what it also brings for us, as we stand, we're very proud to have led the way in launching the Africa's Network on Epidemiology, because it has enabled us as a department. Knowing South Africa, we have an added burden, which are the drugs we are dealing with are designer drugs and not necessarily your everyday drug. But it forces overdose because the quality of the drug is never the same. It forces us to actually begin to deal with pre-detoxification, because the mixtures of these designer drugs, be it nyaupe, be it wunga, it depends on where the addict bodied at a particular day. And that has put our rehabilitation facilities under pressure. And we need to say we've increased. We look back as the government, we have increased free access services for rehabilitation by bringing online this year more than 3 government-owned treatment facilities, which has made it possible for us to have a government-owned rehab facility in all 9 provinces, and that has increased access to services. The last point for us that we think we will be dealing with throughout the 6 services that we also have the African Union to thank for, is we need to never forget, in whatever discussion, whether it's harm reduction, whether it's supply reduction, whether it's demand reduction, we must never lose the reality that a lot of Africans have no access to the basic pain medication, that a lot of our African countries are still having challenges in terms of their epidemiological surveillance, that they still have a challenge with the realities of ensuring that the services are actually moved away, and the service users are moved away from the criminal justice system into the welfare and social sector. Therefore, in all of what we will discuss, as Africans, our concern and our issues remain the universalization of each and every drug-related policy recommendations that will be made, but also policies that enable us to not move away from our cultural dynamics that makes us who we are, and utilizing that which makes us Africans to actually inform policy and multilateral policy shifts in the drug space. But last and not least, we must never lose the reality of the contribution that in the use and abuse. The use, misuse, and abuse of drugs. It plays a role, and for us as a continent that is still developing, COVID did not do us any favors. It left us even more worse off in terms of our health services that are overburdened, overwhelmed, and by virtue making insufficient services that are linked to the health system a real challenge at this time. But thank you so much, and I hope the many other series would look at a lot of the issues that we are visiting and all of the relevant departments. All of South Africa's departments that are recognized in the drug master plan as coordinating departments are represented throughout the conference, from the justice cluster, from the social cluster, from the health cluster, as well as from the economic cluster. Because as a country, as we go into the space of cannabis and the commercialization thereof, we are also making sure that in that we don't lose the prevention of drug use and misuse, but support, care, and access to very needed treatment for those that found themselves using drugs. Thank you so much. Also, we hope and look forward to
Thank you, Deputy Minister.
Assisting us as government in bringing the price of the relevant access to medicines for real. Thank you very much. Let's reduce the price of medicines. Thank you so much.
Thank you, Deputy Minister. We saw the challenge of connectivity across the world, and yet at the same time, we heard so much of a challenge of so many important and necessary issues that need to be debated and followed through. And it's so important, crucial to have government support and engagement with us in our efforts so that we can work together to address some of the very important issues that you raised, particularly for your beautiful country of South Africa. So thank you so much for your time and input. To those who missed because of some of the connectivity issues, there is going to be access to the contributions that people can access online afterwards to download. I want to quickly move on to introducing Her Excellency Amira Elfadil, who's the Commissioner for Social Affairs at the African Union Commission. Again, last but certainly not least, the African Union Commission has been the key organization that has enabled us to offer this event. As you know, the annual meeting of the African Union Commission was planned and was going to take place in South Africa, and then COVID came along, and they supported our idea to have a virtual conference and to support that effort. We know that they will still seek to have their own meeting in the new year, but they didn't leave us alone. They supported us actively to make this event happen, and we truly appreciate that. So, Your Excellency, can I call on you to formally open the conference, and thank you and your colleagues for all your support.
Thank you very much, and thank you for your kind words, and good afternoon. Assalamu alaikum, everybody. My apologies, I was only connected through audio. Just a few minutes I managed to be with you. Thank you very much. Let me start by thanking the teamwork we are doing, all of us together. And I would like to recall here the saying that no one person can whistle a symphony. It takes an orchestra to play it. So we are one orchestra in this fighting of drugs, whether globally or in Africa. It's also at continental level, I would like to thank Honorable Bogopane-Zulu, which has been our champion in drug demand reduction. In 2016, she led the African Union in articulating the common African position at the UN General Assembly, a special session on the world drug problem, and she did so in her capacity as the chair of the Bureau of the African Union Specialized Technical Committee on Health, Population and Drug Control, and this is a ministerial STC. We are also grateful to CICAD for the sustained intercontinental dialogue between Africa, Latin America, and the Caribbean. We are very grateful to Mr. Brian. Thank you for also the financial and the technical support to our programs. Thank you very much, Brian. Thank you for ISSUP. We are encouraged by the commitment to the development of professionals in substance use prevention, treatment, and recovery. Also, UNODC Colombo Plan. Also, we consider you our comrade, in arms. Thank you very much. The African Union supports this collaboration. We support this collaboration of different organizations to discuss where we are now, and also where we need to go, and how we are to get there in order to improve our initiatives on drug use prevention, on treatment and care, as well as epidemiology. Excellencies, ladies and gentlemen, the African Union is committed to providing political leadership needed to push forward the agenda for the health and well-being of its citizens. Our policy organs of the AU have been proactive and remain vigilant in promoting a balanced and integrated approach to drug control in our continent. I would like to give very quickly a few examples. For example, at the policy level, the African Union recently approved a new comprehensive plan of action on drug control and crime prevention 2019-2023, helping us to refocus attention on the most vulnerable and hard to reach. The AU continues also to advocate for evidence-based responses to the health and social harms related to drugs, and respect for human rights, including the rights of people who use drugs, is at the center of our initiatives. Another example in the area of drug demand reduction, the African Union facilitated the establishment and the strengthening of national drug epidemiology systems in 30 African member states, which led to the production of 2 continental reports with data for the period 2017-2019, and this is also a very good achievement. In the area of prevention and treatment, regional masters, the training programs using the universal treatment curriculum for substance use disorders have been rolled out. Member states have also been implementing African Union continental minimum quality standards for drug treatment 2012. We also produced a compendium of best practices in the prevention and treatment of substance use disorders on the continent, and we managed also to disseminate this compendium. We participated also in the meeting I think in Vienna also with this compendium. We had a side event, but also it's been shared, widely shared with our member states and with our different stakeholders. Also, my department has also developed and is coordinating implementation of the African Union Comprehensive Socioeconomic response to the COVID-19 health pandemic, which incorporates drug control sector responses. Maybe most of you are aware that Social Affairs Department also is responsible about health issues. We are responsible about dealing with pandemics in Africa, and we are the one responsible now through our specialized technical institution, the Africa Center for Disease Control and Prevention, which is under my department. It is the technical institution that's leading the fight against COVID-19 in Africa. We are doing it on behalf of the continent, and I'm pleased to share with you that we are succeeding to a large extent. COVID-19 is not far, is still going on. It's far from over, unfortunately, but Africa decided to act as one. And this is very important for me to mention in this meeting, that we decided as a continent that this fight cannot be done by individual countries. So we decided to do it as a one. The togetherness is helping us. The united efforts is helping the continent. So we have established an anti-COVID-19 response fund to resolve the issue of the financial resources shortage, and it's very successful, this fund. We have also managed to create an electronic platform for the purchase of the medical supplies, and the private sector in Africa is fully engaged, and we are buying all the required medical equipment needed for the COVID-19 fight. We are buying it through this electronic platform. It's led by Strive Sewa from South Africa, and the president of South Africa, as the chair of the African Union, is leading actually this fight on behalf of the continent. We appreciate very much the leadership of the president of South Africa, His Excellency President Ramaphosa, and I commend highly his efforts and the efforts of my chairperson, His Excellency Musa Faki Mohammed. But I can attest, as a leading person in this fight against COVID-19, that Africa is doing its best, and hopefully will continue to be the least affected continent in the world. Excellencies, because of time, I cannot spell out all our initiatives, but I trust you will hear more from our experts, and also Dr. Jane. She's going to have a presentation. I appreciate here the efforts of my director, Madam Sisi, and Dr. Jane and her team, Abel and all the team. They are really leading with you. I know you all you know them very well. You know Jane, you know Abel, you know our director, and all the rest of the experts. They are working with you very closely. My role is very limited compared to their role, but I appreciate them very much. In conclusion, let me conclude to say that for us to build our own beneficial partnership to strengthen overall coordination, strategic guidance, training, and dissemination of good practices to assist our member states in addressing the world drug problem. We will continue to do it with your help, with your support. It is only by working together that we can find practical solutions to the challenges which confront us. The challenges are many and may sometimes be difficult to overcome, but they are not unsolvable. They are not insurmountable if it's being addressed in common purpose. After saying what these remarks, I would like to be honored, and thank you. I thank you again by honoring me. It's my singular honor to declare this first virtual continental conference on drug demand reduction officially open. I wish you a fruitful deliberations. I thank all of you, and my apologies if I did not manage to mention you by name one by one, but I appreciate all of you, and I appreciate South Africa's role, and appreciate my sister, the minister, for the good work she's doing. Thank you very much. Thank you, all of you partners, and I will be listening to the presentations. Thank you, and thank you for listening.
Thank you very much, Your Excellency, for the welcome remarks and also for opening the conference. Thank you very much to all of our distinguished guests for your inspiring welcome remarks. We have really noticed over the past months that during this pandemic, the value of being interconnected and of collaborating with other organizations, with institutions and professionals has become even more apparent and more important. So we really believe that we can achieve building stronger partnerships and exchange of knowledge and experience through events like this one. So thank you all for your support and for providing your welcome remarks. Our first panel now, we will move on now and start again. To all the attendees, we will have a Q&A session at the end. So if you could send us your questions during the presentations, that would be great, and we will then be compiling them. So our First panel will provide us with a global overview of drug use, and it is my pleasure to welcome Chloé Carpentier and Giovanna Campello from the United Nations Office on Drugs and Crime, also known as UNODC. I would like to introduce our first panelist, Chloé Carpentier, who is the chief of the drug research section at UNODC, with over 25 years of experience at the national, European, and global level in monitoring, analysis, and research on illicit drugs. Chloé is leading the drug research team at UNODC. She oversees research activities in a number of areas relating to drug markets, including their intersection with different aspects of development, such as health, economy, peace and security, governments, and the rule of law. In particular, she counts among her responsibilities the annual production of the World Drug Report. Chloé started her career in 1994 at the French Observatory on Drugs and Drug Addictions, where she produced the first French national report on drugs in 1995. In 1998, she moved to the European Monitoring Center for Drugs and Drug Addiction, EMCDDA, where she worked until 2014, mainly on drug markets, drug-related crime, and drug supply reduction, with a coordinator role from 2008. Over to you. Thank you very much, Chloé and Giovanna.
Good afternoon, everyone. It's really a pleasure to be here with you and an honor. I'd like to thank particularly ISSUP and the African Union for inviting the UNODC to set the scene and to provide you with an overview of drug use at a global level. Well, it's a challenge. In 10 minutes to give you a tour will be difficult, but I'll do my maximum. Now I will share my screen. Does it work?
Yes, yes, we can see your screen. We cannot yet see your presentation.
Yes, I realize that.
Okay, perfect.
I think I just need to change some. Yes. Do you see it full screen?
Excellent. Perfect. Yes.
Yes. Okay. So what comes out perhaps first from our latest analysis is the expansion of the global drug market, with 30% more drug users in the last decade, with drug-related deaths which have increased by a quarter, with record high levels of cocaine manufacture, also opium production, and seizures of amphetamines type stimulants, which have also multiplied by 4 in the last decade. So really an expansion with a number of factors: population growth, urbanization, and others too. Now, if we look at this expansion, especially it's marked in developing countries, and I think this is also important for some African countries. We've seen the last 2 decades a growth by 28% in developing countries of the population, which compared to 7% in developed countries. So this is much more. And what is striking is that the population of the young adults, those between 18 and 25 years old, grew by 18% in these developing countries, whereas they decreased by 10% in developed countries. And this is, in the young adult, this is where most of the drug use is concentrated. So this is also a factor. Now, the other element that comes out of analysis is the increased complexity of the global drug market, with a number of elements that relate to drug use. In particular, the increasing overlap between legal and illegal markets, with an increasing use in some countries or also mixed with other substances of non-medical use of pharmaceutical drugs, polydrug use, and the continuous entering on the market of new psychoactive substances which are not controlled. And regarding this NPS market, we see that it's in constant state of flux. Many substances emerge, but others also come out of the market. And some stay, are more resilient, and some of them create niche markets among vulnerable population groups, for example, those who are homeless, but also some groups in prison. So this is a worrying trend. And there is also an increasing number of these NPS, which are of the opioid group. Now, I've mentioned the number of drug users that is on the rise. We estimate today that there are about 270 million people who have used drugs in the past year, and 35 million people with drug use disorders. Of those who have used drugs in the past year, most are those who use cannabis, 192 million, and about 60 million have used opioids in the last year. Half of them have used plant-based opioids, so the traditional heroin or opium, but another half, so 28 millions, have used synthetic opioids, so mostly pharmaceutical opioids. Now we continue to see that cannabis use is higher in youth, in young people between 15 and 16, as compared to the adult population, the general population, in all the regions but one. This one is Africa. In Africa, the prevalence seems to be quite comparable. That said, the estimates for the young people has a precision which is quite low, so this may come from that we don't have much data on this continent, this region, but also perhaps because of stigmatization, young people may be reluctant to report their drug use, so it may be underestimated in that region. While the largest number of drug users in the past year is of cannabis, opioids continue to account for most of the harm attributed to drug use and drug use disorders. There is an estimate of 42 million years of healthy life lost due to drug use for 1 year, and half of these are due to opioids. So opioids really result in a large share of this harm. Now, here you can see, continuing on opioid, the main type of opioid that is used in different countries around the world, with pharmaceutical opioids, mainly in North America, in Oceania, and in a few countries here and there. And the rest of the world is dominated by heroin. Opium is only around Afghanistan where this is produced. But now you see also on this map that in the African region, there are many countries for which we don't have data. If I continue on opioids here, you can see the different levels of prevalence estimated for different regions and sub-regions of opioids and opiates. Opiates being part of opioids on this graph. So the difference is basically the synthetic opioids or the pharmaceutical opioids, which are extremely high. You can see on the left in North America and in Oceania, and all the rest of the world is the levels basically of opiate use in the last year. Now, if I continue on the main stimulant drugs that are used, we also look at the different traditions in the different countries around the world, and we see the Americas dominated by cocaine, but also Western Europe, many countries in Africa, most of them, at least those who report, and in Oceania. And then you have another set of countries in Central and Western Europe, also Nordic countries in Europe, and in Asia, Northwest Central, dominated by amphetamine, and East and Southeast Asia dominated by methamphetamine. In terms of prevalence, you see here on the left the use of amphetamines, so both including amphetamine and methamphetamine in different regions, and relatively high in the Americas and in Oceania. And on the right, you see the prevalence of use in the last year of ecstasy, which in every region is lower than the use of amphetamine, except perhaps in Europe and in Oceania, where the levels are higher. I've mentioned drug use in prison earlier. I mean, we have estimated that 1 in 3 people in prison have used drugs at least once during their incarceration. This is extremely high. This is during their lifetime, but still it's extremely high. While perhaps mostly it's a use of cannabis, what we saw is that those who have used heroin in the past month are more frequent than for any other drug. So this is also worrying. And what is also worrying is that we estimate that 1 in 10 people in prison has a history of injecting drug use. And with the fact that in many prisons around the world, there is no access to safe and clean injecting equipment, there is, of course, the risk environment for the spread of infectious disease, HIV included. Here you can see the distribution of different drugs for which people with drug use disorder are in drug treatment. And so in Asia and Europe, it's dominated, these drug use disorders are dominated by opioid use disorders, whereas in Latin America and the Caribbean by cocaine, and in Africa by cannabis, and the others is a mix basically. What is interesting here that we see now since quite some time is an increase in the proportion of those going into treatment for cannabis use disorders in all the regions, except perhaps Africa, where the proportion is already extremely high. We estimate that a bit more than 11 million of people are injecting drugs, are drug injectors, and half of them are living with hepatitis C, and 1 in 8 are living with HIV. On this map, we have represented the prevalence of people who inject drugs by subregion. This is the region or the subregions which are colored. And you see here that Africa fares relatively well compared to the rest of the world, with comparatively low prevalence of people who inject drugs. But in the bubbles, you see the prevalence of those living with HIV among these people who inject drugs by region or sub-region. And here you see that perhaps Africa, compared to other regions, doesn't fare so low. It depends on the regions, basically. And for my last slide, I wanted to focus a bit more on drug-related death. I've mentioned before that drug-related death as a book number have increased by 1/4 in the last decade. They're estimated at just under 600,000 for the last year that we have an estimate, 2017. And half of these drug-related deaths are related to hepatitis C. So here we are basically mentioning drug-related deaths which are indirect. And then if we look at the direct drug-related deaths, so those related to drug use disorders, 2/3 of them are related to opioid use disorders. And these have not increased by 1/4, but have increased by much more. And over the last 15 years, they have increased by 60%. So this is also a very worrying development. Thank you very much.
Thank you very much, Chloé, for giving us such a succinct summary. As you said, 10 minutes is nothing. And also thank you very much for showing us how Africa compares to the rest of the world. That was very interesting. Thank you very much. I would now like to introduce our next speaker, Giovanna Campello. She is the Chief of the Prevention, Treatment and Rehabilitation Section at the United Nations Office on Drugs and Crime. Giovanna has more than 20 years of experience with UNODC in supporting the member states and stakeholders at all levels in improving their drug prevention response, applying and contributing to scientific evidence. Most notably in this context, she has led the publication of International Standards of Drug Use Prevention in 2013 and the UNODC WHO second updated edition in 2018. Since 2016, Giovanna has been leading the Prevention, Treatment and Rehabilitation section of UNODC and thus promoting evidence-based gender and human rights sensitive practice on drug prevention, treatment, care and rehabilitation, as well as access to controlled drug and medical purposes. Giovanna has a Bachelor of Science in International Relations from the London School of Economics and Political Science and a Master of Arts in Gender and Development from the Institute of Development Studies of the University of Sussex in the UK. Thank you very much for being with us, Giovanna.
Thank you, Livia, and Excellencies and dear friends and colleagues. Thank you so much for having me and having UNODC, and it's a great honor. And thank you, Chloé, for giving us the overview of the situation from the epidemiological point of view, because that leaves me the opportunity to focus on what I think are the issues that arise from this situation. So some of these pictures you have seen already. Chloé just showed them to us, and she talked to us about the expansion, the complexity, the increase on the number of NPS, and these are all really important issues that we need to start and get our head around and tackling. But I think that also the real tragedy is at the level of the people. And in reality, I would like to start from something that is an old piece of data that indeed Chloé's section elaborated, and the fact that there are too few people with drug use disorders that have access to evidence-based treatment and care. And the latest global figure is 1 in 8, but we know that this hides very difficult situation in certain regions. It hides a very difficult situation for adolescents and for women. This picture that is actually from Senegal is actually a happy picture because it shows good treatment and good treatment. But we know that the figure that we have doesn't mean that people who are in treatment are in evidence-based treatment. And this is a real tragedy for the 35, I don't know why this keeps on changing, the 35 million people with drug use disorder worldwide. And we know that this is very much compounded by the issue of inequality. The World Drug Report this year dedicated an entire booklet to the issue of inequality, and this is a study that came out just after that, looking at data from more than 50,000 students in 28 European countries, and showing very clearly that more frequent use of cannabis is linked to low socioeconomic status. And the booklet of the World Drug Report clearly analyzes the situation for which we know that rich people might be using more, but drug use disorders are more concentrated in people of lower socioeconomic settings that have also less resources to address them. And this starts to compound a really serious situation. And Chloé has already mentioned and extensively highlighted for us the very serious consequences in terms of disability-adjusted life years, overdoses, drug-related deaths, HIV, hepatitis C, and I would also add mental health disorders and comorbidities. And to all this, some of the earlier speakers have already mentioned how we need to add the issue of COVID, and we have seen that in many countries, the services for people with drug use disorders were not put in the list of essential services, leading to services being closed or discontinued or severely curtailed. And ever since March, we have put out some suggestions for member states and to support treatment services all around the world on how to make sure that treatment, care, and rehabilitation services continue also in the context of the pandemic. And some of the distinguished speakers mentioned prevention, and if the situation is severe with treatment, for prevention in a sense is even worse. We don't even have a real how can I say, a figure for how many people are covered by evidence-based prevention. We just know that there is no real investment in evidence-based prevention worldwide, meaning the prevention that follows the international standards that we have published with the World Health Organization, and there really is an investment in the healthy and safe development of children and youth. And again, this is something that has been compounded very much in terms of seriousness by the COVID-19 pandemic that has put enormous stress on families and parents. And we have seen rates of violence in the family against women and children going up. And that is why we have developed a range of tools for parents on how to deal with this difficult situation in a way that protects the children and does not put them at further risk for of mental health disorder now and in the future. The other problem, Chloé was showing us the data about drug use in prison. There are just too many people with drug use disorders that are in prison or in contact with the criminal justice system and with no access to treatment. And this is a danger to themselves and to society as a whole. And finally, there are too many people that do not have access to control medicines. We are talking about 80% of the world populations, most of which in low and middle income countries. And here I was for thinking that I would need to maybe justify why I would be talking about access in this in the context of this presentation. But the Honorable Minister preceded me and made it very clear why this is a very, very needed discussion. If people do not have access in the national health system to control medicines, they will try to find the controlled medicines in the illegal markets. And this means more drug trafficking. This means people who use medicines that may not be effective or even toxic. Or they may use medicines with no adequate medical supervisions, which means the danger of higher drug use disorders. So yes, there are issues of price. There are many different issues. And again, I invite you to read the dedicated booklet in the World Drug Report about this. And it is a conversation that we can and we should be addressing. And you know, maybe you might be thinking, oh, like this beautiful lion. Giovanna, isn't this what you have been telling us for a long, long time? How, yes, there are new figures, but isn't this the usual saying, too little prevention, too little treatment, too little access? Well, yes, indeed. And the problem is that we know what needs to be done, but we don't put it in practice, right? Or we don't put it in practice enough. And some of my colleagues have already mentioned some of the tools that are already at the disposal of everybody to address this situation. And I would like to reiterate their existence and maybe also point you to something new. So, for example, we have excellent tools to support the development of children and youth working with families and schools, also in very, very poor or violent communities. So let's use these tools. We have tools to increase youth participation. And here I would like to highlight a new piece of research for you. This is a very recent review of evidence in low and middle income countries that really reports positive results in terms of prevention for youth engagement. So a new tool in addition to the one that we have, those that we have already listed in the international standards on drug use prevention. For treatment, we have the international standards that we have published with WHO, and together with all of the partners that are represented here today and more, we have been developing tools for countries to develop mechanisms to assure and improve the quality of drug treatment on a continuous basis. They are at your disposal. And in terms of people being and I would like to also note that indeed, as Chloé was mentioning, a lot of the negative health and social consequences, particularly drug-related death, are linked to opioid use. But there are loads of people that are using stimulants. In many countries, the prevalence is swinging from opioid use to the stimulant use, and national treatment systems are very, very unprepared. We have the tools, and there is new research and evidence on even medically assisted treatment for stimulant use disorders. So let's join forces to strengthen this part of the treatment systems as well. And let's also join forces between the health sector and the criminal justice sector to provide alternatives to people with drug use disorder to incarceration and punishment. There are many, many ways in which this can be done, and that thus reduce overdose and also provide services in the prison settings, all things that strengthen health in the community as well. So same old, dear lion. Well, let me take you by the paw and let us use together all of the tools that we have at our disposal. And I want to, make a pledge and mobilize, and maybe inspire you to mobilize further. We have ISSUP. There are, I don't know how many people on air, more than 600, more than 650 people on air. If each one of us takes by the hand somebody else who is not in this meeting, but might be related to this kind of work, can you imagine how many we would be and how much we can increase the political will and the resources to really invest in evidence-based prevention, treatment, and access, because this really means increasing the health, well-being, and security for all. So I hope that I've inspired you a little bit. I wish you all the best. This is a great conference, and let's go even beyond it. Thank you so very much.
Giovanna, I hope you can hear me. And I just want to say thank you. Can you hear me? I want to say thank you so much for giving your time again today, your continued inspiration and work and support for all that goes on in drug demand reduction to us all. Has been so long-standing. You're always there to give us help and support. We know that there are so many demands on your time, and we thank you so much for being there and for all you've done. I can only share with you the view that if we can look at how we can translate what not only what we say in this conference, but how we translate it into what we do as a result of this conference, think of the impact that we could make. After it's my mantra, after all is said and done, there's a lot more said than done. And I know you have been one person that's inspired us to do things. So thank you so much for your contribution, for your continued input and support. It's always inspiring to have both the evidence, the data, but also the emotion and energy that says, well, let's do something about it. Thank you.
Thank you.
Can I move on then, ladies and gentlemen, to our next speaker? I'd like to introduce Dr. Jane Marie Ongolo from the African Union Commission. Jane has been a long-time champion of drug demand reduction in Africa and internationally. She is a force to be reckoned with, but we all know that she's been there to positively give input and support to all that we do and to the work of the African Commission, but to all of us who work in the field. So it's a privilege for me to introduce Dr. Ongolo. She's the head of social welfare, vulnerable groups and drug control at the African Union Commission, based in Addis Ababa in Ethiopia. She is a social development specialist with substantial cross-functional skills. That's impressive, cross-functional skills. You'll have to learn that one, Jane. In representation and liaison, advocacy, strategic management, and organizational development, which shows the strength and range of things that she offers. She's currently heading the Division of Social Welfare, Vulnerable Groups and Drug Control at the African Commission, and her work includes coordinating policy action with African Union member states in the development and implementation of social development policies and programs. There's much more that could be said about Jane's past and her work and contribution, but I'd rather just move on to give time to listen to what she has to say to us today about the overview of drug use in Africa and the continental perspective of the issue. Thank you, Jane, for being with us.
Thank you very much, Jeff. And I stand on existing protocols. It's my pleasure to present on behalf of the African Union Commission an overview of drug abuse in the continent. And allow me just to acknowledge again the presence of my Commissioner, Excellency Amira Elfadil, whose leadership has really facilitated the work that we do in the continent. Part of what I'll present reflects already trends that have been articulately presented by Chloé, but I'll zoom in a little bit into what it means in Africa. Yes, I'm sharing my screen. I hope it's visible. Okay. One moment, Jeff, I'm struggling with my presentation. I think I got it now. I'll briefly look at the situation of drug abuse in the continent, zeroing in on some of the substances of abuse, particularly from data that has been collected directly from Africa. As we all know, really, consumption of psychoactive substances is not new in Africa. It's been an age-old practice for medicinal, ceremonial purposes. But problematic drug use has recently emerged when Africa became a transit region in the global drugs trade. As you can see from this map, all types of routes, drug trafficking routes crisscross Africa. For heroin routes, we see those cocaine routes and also methamphetamine routes. My slides are not fully showing on the screen, so I'll be speaking from my laptop as well. So the drug trafficking across the continent has brought really significant threats to security, health, and rule of law issues, and we are witnessing exponential growth of drug users in Africa. According to data from UNODC for 2019, 210 million people, which is about 4.8% of the global population, aged 15 to 64 used drugs. This is compared to data that has been collected by ENACT and Institute of Social Security Studies, which indicate that 9 million people in Africa, or 16% of the population, have used drugs. Modeling projections to 2050 are not really encouraging. It indicates that by 2050, drug users will have increased by 50%. So consumption of excuse me, working on two screens. So if we look at trends overviews from the World Drug Report, we see that when we look at opiates, 0.3% of the population in Africa have used drugs, but this also represents 2% of the global trade. Consumption of opiates, especially heroin, is mostly noticeable along the East African coast. That's in Kenya, Mauritius, Seychelles, United Republic of Tanzania. And this region remains significant entry point for heroin in Africa, both as destination and as destination as well as transit. If we look at tramadol, 3% of the population have used, and this represents 79% of global seizures. And we also noticed that 4.6 million people are estimated to have used tramadol in West Africa, Central Africa, and North Africa. When we look at cocaine, 4% of the population have used in Africa, and specifically West and Central Africa have witnessed the largest cocaine seizures in Africa over the last 2 decades. When it comes to ATS, amphetamine type stimulants, excluding ecstasy, 0.9% of the population have used in Africa. And generally, Egypt, Sudan, Nigeria, and South Africa have reported largest quantities of seizures in the period 2014 to 2018. For cannabis, again, as Chloé had mentioned earlier on, Africa has witnessed higher than the global average of consumption, with Africa having consumed at 12.45% compared to the global average of 3.8%. And Africa also accounted for almost 60% of cannabis resin seized globally. Okay.
Okay, Jane-Marie, we have basically just put up your presentation because we were feeling that you weren't able to move to the next slide. So we have it open now. So if you could tell us which slide you're on, we can move it for you.
Next.
Okay.
You can move. Next.
Yeah.
Next. Next. When we look at cannabis trends, and again, these are figures from the World Drug Report, Africa represents higher global consumption at 12.45% compared to global average of 38%. And we see that Africa accounted for almost 60% of cannabis resin seized globally in 2018. Next. So, the main types of substances of abuse in Africa, majorly from data that has been collected from Africa. Over the last 5 years, we established what we called Pan-Africa Network on Drug Epidemiology, which has been collecting data from 2016 to the current period. So from this report, AU member states reported high prevalence of 2 types of drugs, alcohol and cannabis, among people who are seeking treatment for substance use facilities across the continent. So where one was the primary substance, the other it tended to be the secondary substance, except in a couple of cases where opiates, including tramadol and cocaine, were the secondary substances of abuse in treatment populations, especially in Egypt and Nigeria. Next. From the data that was collected from 2016 from treatment facilities, we can see that the primary and secondary drugs of abuse were mainly cannabis and alcohol being primary, and secondary ones being opiates, and to some extent, we have, I think in the next slide, we have also cocaine. And I want to stress the difference between what I presented from the World Drug Report and what I'm presenting from data that was collected in the treatment center. When we looked at trends from the World Drug Report, we see that 0.4% of the population in Africa have consumed cocaine. But when we look at treatment data from those who sought treatment from treatment facilities, cocaine is not featuring very well, which can also be talking to the type of treatment services that's available in the continent. So in 2016, we don't actually even see cocaine featuring from any of the treatment centers. And next. In 2017, we see cocaine as secondary drug of abuse in Guinea. And another drug that has been introduced, which I'll talk to later on, is indigenous to a concoction indigenous to Africa called Nyeupe. So I would like viewers for our member states who are looking at this, if you can really take particular notice of this slide and the previous one, if we can just go back again. The previous slide. These are the facts as we have it coming directly from data that has been collected from member states. So we really need to take particular notice of the type of services that people are seeking from us and actually receiving from us. Next. Next and next. Okay. So other substances of abuse, cannabis clearly remains the region's most commonly used drug. As we've seen, it has higher prevalence in Africa than the global average, but we're beginning to see a range of drugs and drug markets expanding and diversifying. Cocaine markets are emerging and opiate markets seems to be expanding as well. But we've also seen the non-medical use of prescription drugs such as tramadol. But our practitioners are also struggling to address new challenges and new forms of addictions, such as those presented by the new psychoactive substances. And the new psychoactive substances, they change and new ones come in the market every day. Next slide, please. So in terms of pharmaceutical opioids, we've already talked at length about tramadol, which is mainly consumed in Northern Africa, West and Central Africa, but we also have codeine, which is a cough syrup, mainly consumed in Southern African region. Next. I mentioned earlier that we've established in Africa the Pan-African Network on Drug Use, Epidemiology, PAENDU, and currently 30 countries, 30 national epidemiology networks have been formed. And out of the 30 countries, 15% or 50% of those countries have reported cocaine being present in their countries, and those are Comoro, Madagascar, Tanzania, Mauritius, Mozambique, South Africa, Lesotho, Kenya, and Senegal. But it's also interesting that many countries report the presence of injecting drug use, and really the number of countries that have this is quite significant. So if we compare this with the figures of the type of treatment that people seek from treatment centers, we begin to see that there's a bit of mismatch, and IDU is beginning to be very important and is something that we need to focus attention on. Next slide, please. So beyond opiates and alcohol, we have new psychoactive substances that I've mentioned about. And For this, I'm going to mention about 3 substances that are really specific to this region. We have something called lizard parts and dung. It's known to possess psychoactive qualities and is mainly rampant in Africa. We have what we call nyeupe or wanga. It's a cocktail of antiretroviral drugs, low-grade heroin, marijuana, and sometimes rat poison. This is mainly prevalent in the Southern African region, but we also have many countries with a combination of sniffing of glue, petrol, sewage, and urine as inhalants. Next slide, please. We also have cat in Africa, cat or chat, as it's known in many places, or mira, as it is also known in many places with that name. It's a plant-based substance, currently not under international control, and is mainly consumed in the Horn of Africa countries. Concerns about the harm associated with chat and the combination of cat with other substances has led to its control in Eritrea, Madagascar, Rwanda, Sudan, and Tanzania. But we know cat is not under international control at the moment. But we've also seen an emerging use of rohypnol, whose street name is green beans, rafts, 552, blue boys, or rocher, depending on where you come from in the continent. And when rohypnol is ingested, after 20 minutes, the effects of the high will kick in. This is why it's mostly used as a date rape drug internationally, but as well as in Africa. Next, please. So looking at that quick scenario of the drug situation in Africa versus the prevention and treatment infrastructure, over the last 10 years, we've seen an appreciable improvement in treatment facilities. Of course, a lot still needs to be done, but I would like here to also acknowledge the partnership that we've had with UNODC, with the Colombo Plan, through the various training programs that have really enhanced the capability of different member states to be able to offer treatment for those who are seeking. But range of treatment options still limited, as you've seen in the slides that I showed, for people who are seeking treatment, that some treatment options were really not available. And again, as Giovanna had mentioned, only 1 out of 18 people who are needing drug treatment receive in Africa, receive globally, receive in Africa compared to 1/6 globally. Treatment in prison settings or alternatives to incarceration is still limited, and this is a subject of a separate webinar that we are having tomorrow. We'll be addressing this. Social protection coverage for people who use drugs is not universal globally, but also in Africa. And we also see that evidence-based prevention, public awareness, and community involvement is presently inadequate. Next, please. So to address, AU has put in place a number of policy and programmatic efforts. We have the African Developmental Blueprint, Agenda 2063, and its Social Agenda 2063, whose principles talk about leaving no one behind, including putting in place measures to address vulnerabilities and various risks, including for those with drug use. But of course, then we have our AU Plan of Action on Drug Control and Crime Prevention, which Dr. Abel will be presenting about later on. We have the African Union Comprehensive Socio-Economic Response to COVID-19 and the health pandemic. And I really would like to say that this particular document plus the AU Agenda 2063 and the Social Agenda 2063 are beginning to link drug use problems with social development and proposing a number of measures that are needed for investment in social development to raise the human capital. At the AU level, we've also been collaborating with a number of organizations to offer training and capacity building, especially ISSUP, the ICUDDR, the Colombo Plan, UNODC, and Organization of American States. Next, please. This was a quick overview of what's happening in Africa, but in conclusion, I would like to leave us with four critical points to ponder over. There's need to build body of evidence. As we've seen from Chloe's presentation and to some extent my presentation, that we don't have sufficient data on the extent of drug use in the continent. So more data could help curb the continent's increase in the use of illegal substances. The second point relates to investment in prevention and treatment. Without belaboring this, we know that it cuts crime, saves money to health, criminal justice, and prisons, promotes better public health outcomes, as the aim of treatment is to help individuals achieve stable long-term recovery and become productive members of society, but also to eliminate the public health, public safety, and economic consequences associated with addiction. And it's also important that as we address drug use, that we invest in balanced approaches. As we've seen, the increase of drug use in Africa is related to Africa being a part of the global trade in narcotics. The biggest challenge for all of us remains for countries to invest sufficiently and scale up. And thank you for your attention. Over to you, Jeff. Thank you.
Let me say thank you to you, Jane, for a fascinating insight into the situation within Africa. Tremendous challenges there, as ever, for us all to work together to help and support you with. But also there are signs of progress and development with the work of the Commission. Fascinating to hear of the different substances that need to be addressed as we move forward in our efforts. So thank you for your input, Jane, and for your continued support to our work. Can I move on to Dr. Abel Basutu, who's been a key member of our planning team for this conference. He's been quietly behind the scenes and at the front of the scene, helping us to plan and develop and giving us the support of both his own expertise and experience and that from the Commission. So thank you, Abel, for that. Abel is a program specialist with extensive experience in policy formulation and advocacy, management and implementation of technical cooperation projects in diversified development fields, including drug use and prevention and treatment. In protection of children's rights and tackling online child sexual exploitation and abuse has also been one of his focus of work. Started his career as a journalist and is a 9-time winner of Reuters International News Agency Media Excellence Awards. That's 9 times is amazing, well done. He trained as an auditor with Ernst & Young Chartered Accountants and holds a PhD in business administration. So a fascinating background able to bring to the field of drug demand reduction, and we look forward to hearing about the work of the African Union and their plan for the future.
Thank you very much, Jeff, and I think we are good to go. Can you all see my screen?
Yes, we can, Abel.
Yes.
Okay, thank you very much. By way of introduction, I would just briefly say something about the African Union. All protocols observed. African Union is an intergovernmental organization with a membership of 55 African countries, and its role is predicated on the desire to accelerate continental social and economic development. And our working languages, English, French, Arabic, and Portuguese. The African Union Commission is headquartered in Addis Ababa, the capital of Ethiopia, and it is the administrative organ and the executive secretariat of the African Union. And the role of the African Union Commission is to coordinate development of continental policies and to monitor their implementation by member states. So within that spectrum, the Commission does develop capacity of member states, technical teams, and leverages technical assistance through strategic and multilateral partnerships of the African Union. That slide basically shows some of the African Union strategic frameworks in the area of drug control. The African Union Continental Minimum Quality Standards for Drug Treatment, Common Africa Position on Controlled Substances, the Addis Ababa Declaration on Scaling Up Balanced and Integrated Responses, decisions and declarations of sessions of African Union ministerial meetings, drug control action plans for 2015, 17, and 19, but I will focus more on the African Union Plan of Action on Drug Control and Crime Prevention for the period 2019 to 2023. So this AU Plan of Action on Drug Control for the period 2019 to 2023 is the overarching framework that guides drug policy development on the continent. And it is the African Union's fifth strategic continental framework on drug control. And the plan is aligned to Agenda 2063, Africa's Blueprint for Social and Economic Transformation. It is also aligned to UNGA's 2016 outcome document, as well as UN Sustainable Development Goals. The fundamental goal of the plan is to improve health, security, and socio-economic well-being of people of Africa by addressing drug trafficking and problematic drug use in all its forms and manifestation, and preventing the onset of drug use. How was this plan of action developed? It was developed out of a protracted, consultative, and inclusive process, which involved member states' technical experts over a period of many months until it went through validation and its eventual adoption by AUC policy organs. It is anchored on 9 thematic pillars, and the beauty of it is that it has an easy to follow implementation matrix at various levels, at the continental, regional, and national level, and therefore very easy for member states to domesticate and align their policies to continental aspirations. So this slide basically shows the 9 pillars of or the 9 priority areas of the AU Plan of Action on Drug Control and Crime Prevention 2019-2023. The first one there being drug demand reduction, access and availability of controlled substances, crime prevention and criminal justice, evolving realities, challenges, and threats, drug supply reduction. Then we have cross-cutting issues, international and regional cooperation, and continental mechanisms for monitoring and evaluation, and lastly, alternative development or alternative means of livelihood. And I will briefly explain in a brief for each of these pillars what they are about. So this pillar one, measures to address drug demand reduction and health issues associated with the drug use addressed. So this particular pillar is really about scaling up evidence-based services to address health and social impact of drug use in our member states. It is about balanced and integrated multi-sectoral measures for prevention, treatment, and care for drug use disorders. And here we are looking at member states taking measures to increase professionals in prevention, treatment, and care fields, and also issues of pursuing treatment as an alternative to incarceration. I'll move to the second pillar, which is access to and availability of controlled substances facilitated for medical and scientific purposes while still preventing their diversion. So basically, it's self-explanatory, seeking to address barriers that limit availability of controlled substances for medical and scientific purposes while preventing their diversion. We had earlier on the issue of non-medical use of medicines. So pillar 3, measures to address drug supply reduction, scaled up along with countering enablers of drug trafficking, firearms, corruption, and money laundering. So this pillar is basically concerned with measures to counter drug trafficking and its enablers. So that include firearms, trafficking, corruption, money laundering. We are also looking at issues that address violence and related crime. We are also looking at strengthening interministerial collaboration within country, collaboration between law enforcement and other sectors in monitoring drug trafficking and peddling. Pillar number 4, measures to address crime prevention and criminal justice reform implemented. What are we looking at here? We are looking at strengthening criminal justice systems. We are looking at prison law reform. We are looking at improving quality, fairness, and efficiency of the criminal justice system, and enhancing preparedness to fight organized crimes, for example, cybercrime, and addressing transnational organized crime. Pillar 5 is basically on cross-cutting issues focused on drugs, human rights, particularly as they pertain to vulnerable groups that include women, children, and communities. And as you can imagine, there are quite a number of cross-cutting issues there. So we are looking at basically improving the quality of services with respect to dignity and human rights of those in treatment, and including those in correctional facilities as a result of drug offenses. Basically, to ensure also a timely access to legal aid and right to fair trial, enhancing knowledge of policymakers and law enforcement regarding human rights to health, human rights to safety and well-being for all, including, of course, people who use drugs, which means that we need to speak into issues more of moving away from punitive to supportive measures and addressing protective and risk factors that make vulnerable people, particularly girls and women, vulnerable to be recruited as drug couriers. So we are basically looking at those service quality improvements and the other factors, as I mentioned. I will not dwell much on this. I've already alluded to the issue of protecting vulnerable populations that include women, children, as articulated in the African Charter on Human Rights, the African Charter on the Rights and Welfare of the Child, and also the African Youth Charter. But basically also to include issues of strengthening national surveillance systems and strengthening national drug control coordinating mechanisms. The sixth pillar is on evolving reality, trends and circumstances, emerging and persistent challenges and threats, and it's about strengthening measures to reduce availability, distribution and use of new psychoactive substances. We also need to strengthen the regional forensic capacity to identify those new psychoactive substances for early warning and as well as criminal justice systems. Alternative development. We are looking at issues here of promoting implementation of development imperatives that are outlined in the African Union Agenda 2063, as well as UN Sustainable Development Goals for 2030. Strengthening judicial interventions to make it difficult for companies linked to illicit drug production to operate legitimate businesses, and promotion of development of infrastructure in high-risk areas for illicit production, that is infrastructure such as roads, schools, and clinics as a protective factor. Pillar 8 is on strengthening international regional cooperation based on principle of common and shared responsibility. That speaks to issues of mobilizing support from international partners for technical and financial cooperation to implement balanced development-oriented drug policies in member states, and of course, strengthening mutual legal assistance in criminal matters and extradition arrangements among AU member states and also other countries outside the African Union where nationals are investigated for drug offenses. And pillar 9, the last pillar, is on enhancing continental, regional, and national management, oversight, reporting, and monitoring, and evaluation of the African Union Plan of Action. So this pillar is basically concerned with the strengthening capacity of the African Union Commission to manage and coordinate implementation of the Continental Drug Control Framework. So how does the African Union monitor implementation of the Continental Drug Control Framework? So progress in implementing those provisions is reviewed biannually by a forum of ministers of health, population, and drug control through 2 main reports. One of them is a biennial report from member states detailing their progress in the implementation of the African Union Plan of Action on Drug Control and Crime Prevention. So the last biennial meeting was in last year, and next year we are going to have another ministerial forum to monitor this progress. The second report through which progress in implementation of these provisions is monitored is the annual National Drug Epidemiology report. So member states And Dr. Jane alluded to the fact that the AU has facilitated the establishment of national drug surveillance systems in 30 member states out of the 55 African Union member states. So each of those 30 member states is required to submit an annual national drug epidemiology report. So that will enable the ministers to evaluate and monitor progress, as well as to come up with new policies as may be desired. In implementation of the African Union Plan of Action on Drug Control, the African Union doesn't do it on its own. It cooperates with a network of international and regional partners that include UNODC, WHO, INL, International Society of Substance Use Professionals, African Regional Economic Communities, the Inter-American Drug Abuse Control Commission, Colombo Plan, and many other organizations that I did not include in the slide. Thank you very much for your attention. Thank you.
Abel, can I say thank you to you for a very interesting response to the challenge that Jane showed us that there is in Africa, but then to see such a comprehensive response in terms of what you're planning to do, which we obviously wish you luck and hope we can support you with. I love the concept of the pillars. It's not a matter of doing one or the other. All pillars are interdependent, and you have to look at all of those pillars and see how you can move them forward. And I think it's a tremendous comprehensive challenge you've put forward to meet the challenges of that Jane has produced. So together, we wish you luck and thank you for your tremendous contributions today. Thank you very much.
Thank you.
Can I move on to a penultimate presentation, which comes from our INL colleagues. Bill McGlynn has been a tremendous support of the work we've done, certainly within ISSUP, and been part of the planning team and behind its development and the fact that it has actually started to deliver today. And Bruno Bui, who's been also there in the background supporting us at INL with his focus on work in Africa. So thank you to both of you for your input. Bill is a senior advisor to the Bureau of International Narcotics and Law Enforcement Affairs, INL. I can never remember the full explanation, so I just say INL. He has helped to develop and implement international drug treatment and prevention programs in Africa, Asia, and Latin America since 2013. I know he's been particularly involved and interested in the work in Africa. Bill served as Deputy US Permanent Representative to the OAS, and from 2008 to 2011, he was the Principal Deputy Assistant Secretary of INL. Bill, we welcome you, and also Bruno, who has been with INL since 2010. He only started with the drug demand reduction team this year, but is already making his presence felt in the support he's been given to this, and following his work with non-profit organizations that have focused on health issues. We look forward to hearing from you both on the plans from INL. Welcome. Are you there? Bruno, welcome. Can you make sure you unmute, Bruno? We can't hear you. Can you unmute so we can hear you?
Sorry, thank you for the introductions.
Okay.
Good morning, everybody. Good afternoon and good evening in their respective parts of the world. If I can get to the next slide 2, please. Perfect. So just starting off the presentation, wanted to start off on the impact of drug use. And so drug use correlates with criminality, violence, and drug participation, and fuels corruption, all of which undermine stability and the rule of law in partner nations. We know that economic development and productivity are impacted by drug use, with studies showing lost hours of productivity. The social development of children is also impacted by drug use. We know that children with parents who use drugs are more likely to use drugs themselves, causing an intergenerational repeating cycle of drug use, violence, and crime within the home, and the deterioration of the community. We can imagine as professionals how much more complicated our jobs are when we have to address the multidimensional challenges posed and aggravated by drug use. So it's a cross-cutting issue at the heart of public health, criminal justice, social development, and the stability of our societies. Next slide, please. So the DDR interventions provide effective tools for a public health approach to drug use and have demonstrated successful reductions in drug use, neighborhood crime, violence, and gang problems. Supporting effective prevention and treatment practices also helps foreign governments recognize the value of these evidence-based approaches to drug policy. The DDR funds are used annually to develop training materials and a menu of programs that are universally applicable, based on scientifically sound research, and continually updated to ensure adherence to the latest clinical best practices. We have evidence that shows that a reduction in drug use also reduces crime and violence. The way that we do this is through our 4 areas of work. The first is training and strengthening the workforce to provide services and help drug users move away from drugs. The second is developing international standards of treatment and assist countries in adopting these quality measures. The third is strengthening and improving services through the prevention and treatment programs that help address addiction. And lastly, by measuring the projects we implement, we determine what works and for whom. The most important measure we identified that we are succeeding in our overall approach is by increasing the number of workforce staff across the world that are credentialed and trained in our curriculum. We have a goal of increasing it by 15%, and not only the number of staff trained, but also credentialed within the next few years. The good news is that we went from 1,293 credentialed professionals at the end of 2018 to 1,671 at the end of 2019, an increase of 29%. Next slide, please. So it's also important to discuss our short-term and long-term goals that we look to accomplish. We have a 5-year implementation plan program that we are looking to develop. Our short-term goals are to establish a quality standard system with inspection and monitoring forms for governments to look at as templates, which they then can adapt to their specific country. We will provide support through the UNODC for this accreditation program for treatment services. We're also looking to expand our research and data collection efforts to disseminate a lot of these new best practices and scientific studies that are coming out now on addiction. Our long-term goals, however, are really to focus on expanding the credentialing program. For us, it's very important to validate knowledge and skills with examination and credentialing. This is a very high priority that we have one universal system for examination of the drug treatment and prevention workforce. We're in the process of creating our global accreditation system, which is bringing more and more commissions from around the globe that accredit providers into a consortium. We're also looking to deliver virtual training courses through the International Society of Drug Use Professionals, or ISSUP, and we're also working with populations that have special clinical needs. Sometimes general treatment practices is not enough for populations that have unique conditions and factors that require special interventions, specifically for women, children, and displaced peoples. There are special approaches in establishing addiction that need to be considered, and that's why we have the curriculum to do that. Next slide, please. There's a lot going on in this slide, and I will not go into detail, but I would like to mention the areas that were previously discussed. 1, professionalizing the workforce. 2, developing international standards of treatment. 3, strengthening our services. And 4, measuring our program outcomes. We have a lot of different products that we can share with all of you, and we are happy to engage with any government that would like to have access to these products. They are all free and in the public domain and does not always require us to come into a country and conduct a training. Please reach out to us through our email, which would be at the end of this presentation. Next slide, please. Now I would like to talk a little bit about our main curriculum products. As many of you know, we have been supporting the development and dissemination of the Universal Treatment Curriculum and the Universal Prevention Curriculum. This is the most comprehensive body of training materials that we know for the world of the addiction field for counselors, nurses, and those providing psychosocial treatment. We have a basic and advanced series for treatment, and we have a director, coordinator, and an implementer's workforce series for prevention. What we do is work with governments to tailor and adapt the curricula for local context for the countries. And then there are some examples here of the different countries that we've been working in. We now have curriculum in 20 languages in over 60 countries. Next slide, please. So this is just an example of the number of countries that we've been working in. We conduct most of the universal curriculum training in Africa through the Colombo Plan. Colombo Plan is an international organization like the African Union or UNODC and was founded in Asia in 1951, but today works around the world. While we provide them with funding to conduct UTC training throughout the world, they prioritize training for their member states. The Colombo Plan is pleased to continue supporting the training of basic level UTC throughout Africa. However, we would like to encourage governments to join the organization as member states to fully enjoy the benefits of membership. The application process is easy. Any ministry or government agency can join, and the benefits of membership include increased support and technical assistance in the area of drugs. We're happy to connect you with the Colombo Plan Secretariat if you're interested in exploring the possibilities of your government joining this organization. Next slide, please. So this is just to show you that INL works primarily through 5 international organizations, which are the African Union, UNODC, OAS, Colombo Plan, and WHO. Next slide, please. As previously discussed, ISSUP is a global network that was put together to unite the drug treatment and prevention workforce around the world. There is a website where a lot of communication takes place, so I do encourage all of you join at www.issup.net. This website shares knowledge, reports, surveys, statistics, and other information on how to address drug use in the respective countries. There's a policymaker forum, as well as all of our training curriculums are located on this website. ISSUP has also an annual global meeting with one held in 2018, held in Nairobi, Kenya. The next meeting is tentatively scheduled for February 2022 in Abu Dhabi, and we hope that many African governments and substance use disorder professionals will attend this next meeting. We are looking to organize this conference not only face-to-face, but also simultaneously online. To that end, we'll be working with the AUC to invite governments to record virtual presentations for ISSUP on the nature of drug use in their respective countries and the responses. Thirdly, ISSUP hosts and supports national chapters, so we do encourage countries to bring together civil society organizations to launch these national chapters. Next slide, please. So the International Consortium of Universities for Drug Demand Reduction, or ICUDDR, is a network of over 250 universities from around the world. The goal of ICUDDR is to develop an international and regional network of educators to share and disseminate best DDR education content and practices. The ICUDDR Africa region is organized along the lines of the AU structure. There are currently over 16 universities in Africa which are ICUDDR members. In September 2019, a meeting was organized by the African Union Commission in Addis Ababa, and they elected a leadership team and a set of priorities were developed. Next slide, please. So back in 2015, there were no globally accepted standards of what good treatment is and what not is good treatment. We funded a very exhaustive research review for 4 years ending in 2019. We now have the international standards of substance use treatment finalized, and based on this research, we have developed quality standards at a quality level which any treatment program in the world should have irrespective of funding constraints. The 2 main questions under this program are, what are ethical practices that all treatment services should follow, and what are clinical practices that every treatment service should follow. Based on that, we are now inviting governments around the world to join a UNODC program on quality assurance, answering how do you assure quality within your governmental systems, and how do you identify an agency that will be responsible for monitoring treatment programs in a very positive way, helping them achieve international standards. Next slide, please. So in the terms of the dissemination of the curricula in the train-the-trainer model, since 2016, we have 56 countries that have adopted the universal curriculum, including the United States, where we have over 30 universities that are training our materials. We have also developed the quality assurance mechanism to help governments accredit their treatment programs, and we are going to keep on working to expand the number of countries. We've also established over 300 community coalitions, with many more being established. We're also working to develop protocols for special populations, such as those in a humanitarian setting. We conducted a site visit for migrant and refugee populations in Uganda and trafficking in persons victims in Peru, and we are now going to convert that information with UNODC into some protocols on how you address addiction within a humanitarian setting. The idea is that the displacement of these populations serve as a risk factor to consume drugs, and certain protocols and therapies should be adapted to address drug use among these populations. Next slide, please. So a few highlights on this slide are we will start to convert a lot of our courses online, beginning with the universal treatment curriculum in order to reach and ensure more people are receiving the training. We also want to expand the accreditation system for treatment facilities through the quality assurance program with UNODC by at least 5 countries. And we also want to expand community coalitions and support vulnerable and marginalized populations through a new program of alternatives to incarceration, trying to bring drug treatment into the criminal justice system with the goal of receiving a recidivism rate of 15% in 5 years. Next slide, please. So with that, we're still working hard to continue to professionalize the workforce online while we wait things for hopefully to return to a little bit of normalcy. But in the meantime, if there are any questions, please do reach out to us through the demand reduction at state.gov email. And with that, I will turn it over to my colleague, Bill McGlynn.
Thank you very much, Bruno. Thank you very much, Bruno. I think people can hear me. If not, I think someone will let me know.
We can hear you, Bill. We can't see you, but we can hear you.
Okay.
If Bruno turns, that's it. We can see you, and we can see your projector slides. So go ahead, please.
Thank you so much. Again, thank you very much. Particular thanks to ISSUP for organizing this and everyone involved. I think it's been extremely productive. I just want to say a few words to the very impressive number of attendees that I hope you will look closely at the ISSUP.net website and consider becoming a member of ISSUP. It's very important. I think it expands our collaboration, and as Giovanna Campello from the UNODC said, if we can bring more people into this, we can address these issues with even more success. I'll just briefly add to my colleague Bruno Bui's excellent presentation. The focus for the Bureau of International Narcotics and Law Enforcement is to basically understand what the priorities are for other countries and other organizations. And I thought Commissioner Elfadil's analogy to an orchestra was excellent. We certainly consider her and Minister Bogopane-Zulu and NGO leaders such as Roger Weimann and SANCA as conductors of that orchestra. So we pay a lot of attention to what they consider the issues and what is most helpful. So we focus heavily on how can we put this into practice. And as Bruno has outlined, there's a heavy emphasis on supporting training and on mechanisms to improve collaboration. I will just refer briefly to this slide, which tries to capture a lot of great work that's being done in Africa. I won't go over in great detail, however, to say that I think it captures what the African Union has done in establishing the Pan-African Network on Drug Use. That in turn has helped support and identify where training for prevention and treatment can be expanded. And there, a great partner has been the Colombo Plan. And you will hear more from someone who's been at the center of that, George Marime, the head of training for the Colombo Plan, in one of the later sessions. Again, our focus is on what efforts are most helpful for the practitioner in the field. And that, again, is why we want to make sure that people consider joining ISSUP, where they have the resources, the training, the best practices, that we can connect everyone and help address these problems. One final point I want to make is we are making a very, very big effort, as our leader for INL in this area, Brian Morales, mentioned, to go online as much as possible. Again, this meeting is perhaps a fantastic example that would be hard to do and will allow us to reach out even more to an expanded audience. But there have already been some excellent collaborations online that have made this possible. For example, the African Union, working with the International Consortium on Universities for Drug Demand Reduction, ISSUP Nigeria, Martin Ogogwe, and ISSUP Kenya, Beatrice Kathungu, managed to have a very impressive training for treatment, which took place a couple months ago, right in the middle of the pandemic. So I think this is the kind of strength us working together brings. And I think this conference is a very good example of what can be achieved together. Thank you very much.
Okay, can I then just add my thanks to Bill and to Bruno on that. It's always been, whenever I see what INL has done, I take a deep breath, and I'm always reminded of the phrase, it's a rather crude British phrase that says, put your money where your mouth is. And the fact that INL have provided the support and the establishment of an organization like ISSUP is something that people need to stop and think about, because they've enabled and facilitated the debate to build an international sharing of what is best practice, to allow debate, to allow expertise to share what is most effective and what is appropriate in policy and practice. So thank you, Bruno. Thank you, Bill, for that amazing scene of just the range of work that you're doing, and thank you for your support. And now my colleague, Livia. Thank you.
Thank you, Jeff. And again, also from my side, thank you very much, Bill and Bruno, for providing this excellent summary of INL's global drug demand reduction programs and initiatives. I would like to introduce our next speaker. I'm conscious of time, so this is our last speaker, and then we'll still have 15 minutes for a short Q&A session. So we are joined by Marya Hynes from the Inter-American Drug Abuse Control Commission, who will provide us with a regional perspective on Latin America and the Caribbean. Ambassador Namm mentioned at the beginning the importance of the Latin American-African dialogue. The first meeting of that dialogue took place at our joint NACADA, ISSUP, and African Union Drug Demand Reduction Conference in Nairobi in 2018. And it is really wonderful to have CICAD here as well as a partner on this event. Marya Hynes is the head of the Inter-American Observatory on Drugs, that is the research and analysis branch of CICAD. She has worked there since 1997. She received her Master in Health Sciences from Johns Hopkins Bloomberg School of Public Health in 1997, with a focus on drug and alcohol addiction and related mental health conditions. Since then, she has been working at CICAD in the Inter-American Observatory on Drugs, where she develops and leads programs to monitor and evaluate the drug problem in the Western Hemisphere. Marya has authored a variety of reports and scientific articles on drug use in the Americas and is a member of the Scientific Advisory Board for the UNODC World Drug Report. Her work has received international recognition, including the 2015 NIDA Award for International Leadership. Thank you very much, Marya, for being with us.
Thank you very much. Can you hear me okay?
We can hear you okay. We cannot see you, but that's
no,
okay.
I decided to turn off my camera. Maybe I'll pop it on just for a quick hello, but then turn it off because the connection here has been a little unstable. And I think that the presentation will go a little bit more smoothly if I don't have my camera on. So it's not because I'm shy, but I think the presentation will go a little bit more smoothly this way. So I would like to begin just thanking the African Union Commission, ISSUP Africa, ISSUP Global, and USINL, and of course the CICAD Demand Reduction Unit for inviting me to participate in this event. ISSUP does very good work, and I'm always impressed to see the way this organization is able to pull people together from all over the world. I also am conscious of time, so I will keep my presentation as brief as possible. Let's see. How do I, okay, there, the advance is a little bit different. Just to give you a little bit of background on the Inter-American Drug Abuse Control Commission, we are part of an organization called the Organization of American States. Think of us as something like the UN, but for the countries of the Americas. And CICAD is the drug commission within the OAS. So our area is to address the challenges of the drug problem worldwide, and or excuse me, not worldwide, but rather regional level, and help harness the collective capabilities of the countries to develop good drug policy. We have an OAS, the hemispheric strategy was adopted in 2010, but we are in fact updating the new hemispheric strategy as we speak. So there will be a new one by the end of the year, as well as our plan of action, which closes this year in 2020. So there will be, hopefully, by the end of the year this year, a new hemispheric drug strategy and plan of action that will reflect the situation in the hemisphere. Now, the Inter-American Observatory on Drugs, which is the section I'm in charge of, we are the research and analysis branch within CICAD. And most of the work that we do is data-based, so a lot of drug epidemiology, which is what I'll be talking about today, and also some supply-side statistics. I'll speak very briefly about that, but the main point is to understand that the OID, we use the Spanish acronym, we prepare and publish reports on drug use in the Americas on different types of issues. We disseminate standardized protocols. I will discuss a little bit about what those protocols are shortly. And we try and strengthen the national drug observatories. By that, we're referring to the research units within the national drug commissions in our member states. That's one of our primary objectives, and help them to establish good, solid drug information networks and associations with key partners to develop their early warning systems, to perform monitoring and analysis and dissemination of data at the national level. Now, the data I'm going to share with you now was all from the report on drug use in the Americas that we published in 2019. That report compiled an overview of our drug use data in the region. We have data from 33 OAS member states, all of which contributed to this report. What I would like to say and pause on, we work very closely with UNODC on our drug use data. Our mission is a little bit different from UNODC. So although this report and the findings of which I will share with you is based on official data sent by the countries of the Americas, one of the things that makes our data system unique is that it is based on a set of standardized research protocols, epidemiology-based protocols that are used in all of the countries that report data from the Caribbean, and the majority from Latin America as well use our standardized protocols. Those that do not have harmonized their data collection methods with ours, and our original protocols were actually based on the Monitoring the Future from the United States and the National Household Survey, also from the US. So we know that our measures for prevalence in these different populations are in fact taken the same way. We use common methodologies, and the variations are fairly small. That said, I'll talk a little bit about comparability between countries and what the additional issues are that we face when we're doing this kind of data. But just to quote our Executive Secretary, Ambassador Namm, who stated last year that the report represents a robust collaboration with OAS member states on data collection, methodology, and careful analysis by CICAD experts. It provides a snapshot of key indicators on drug consumption across the Americas, as well as unique and valuable information on trends that will assist in the design and implementation of effective drug policies. And that's really what we're trying to get at in the region, is we help the countries develop the data that they need in order to create the best policies to address the particular issues. Now, the data I'm going to share with you, we identified 4 main areas relevant to hemispheric drug policy. One of those are the trends in drug use, and I'll go over just a little bit of that. The early onset of use, that is the use among younger and younger age groups. Issues about use by sex, differences between men and women in their use, and new challenges that we see on the horizon as we're going forward. So in terms of drug use trends, cannabis use among particularly secondary schools, that is high school students, we see that increasing in most of the countries that have trend data. When we look at the general population, we also see in general increases in cannabis use. At the same time, tobacco is going down. In fact, tobacco use appears to be the only substance that's showing systematic decreases in use over time in the general population, and even in, to a lesser extent, secondary school students and university students. Furthermore, on trends, about half of the countries in the Americas show increases in cocaine use among the general population. At the same time, the secondary school students, there's a lot more variability in trends. So we see increases, we see decreases, we see plateaus. It's kind of all over the place, which makes it hard for us to make a clear statement about drug use or about cocaine use in either the general population or the secondary school population. Now, we are aware that at the same time, data from the UN are indicating that the cocaine markets in Latin America in particular are quite hot. So this could be that there is a bit of a lag between what is seen in the market and what is being reported in the national surveys. And when I get down to show you some of the details in the data, we may understand a bit about why that is. So here we are. This is what past year prevalence of marijuana looks like in terms of high school students. We have here Argentina, Barbados, Chile, Colombia, Costa Rica, and El Salvador. And on my next screen, you can see a few more, Grenada, Paraguay, Peru, United States, and Uruguay. And what I'm attempting to show you here are not so much the details of the trends, but rather the variability of the data itself. And if we look at Grenada, Paraguay, Peru, compared with the United States and Uruguay, which are two of the countries that have some of the longest trend lines, some things that really jump out to us. And these are issues when we're talking about comparability across countries and looking at a drug problem at the regional level, is that a lot of the countries only have a couple of data points. Some of those data points are quite old. So we may know something about a drug market, and yet what we're seeing in drug use, the reporting on drug use is behind because countries are not collecting data every year. And one of the things that's very important with trends, looking at your trend line is probably the most important thing that you can do to understand if your drug policy is having the desired impact. At the same time, it's also one of the indicators they're most likely to be out of date. And we see that in different populations. We see that across different countries. And the other thing that I'd like you to be able to look at now, this graph is not in our report. Time-adjusted trends. So what we've done is we have stretched out the years in between the different studies to try and give you a view of what the trend lines would look like if they were all on the same time scale. And what we can see is that there's a lot of variability in the trend lines. And when we used to talk about the United States, used to always be the country with the highest drug use. Well, that's not really the case anymore. We can see a lot of increases, but the magnitude of that increase is also quite different because we have very different prevalence levels among the countries. And so a big increase for a country that has prevalence levels that are, at 2 or 3% looks very different from what a big increase might be interpreted as in a country like the United States or Chile. So I wanted to draw your attention to that because when we compare drug use across countries, this is one of the problems that we deal with, is that the countries are very different, the population sizes are very different, and the years in which they're collecting their data are different, even though they might be asking the same questions. So it's something for us to always keep in mind when we're looking at use and to think about how we can improve, especially when we want to develop global and regional estimates on drug use. So the next main area following trends of use was early onset. And one thing that we can see, and although some of our data is old, but it becomes quite clear, is that drug use is appearing at younger ages in many of the countries. In fact, the youngest age group that we study for secondary school students is the 8th grade. And we can see the 8th graders, which tend to be around 13, 14 years of age. We can see substance use firmly established within those age groups. The younger people begin using drugs, the greater the health risks and other consequences over their lifetime. That has been well established in research. And of course, prevention programs and interventions that can delay that age of first use should be accorded high priority. And that is one of the conclusions that we drew when we looked at our data. So this is what early use looks like to us. This is obviously a point prevalence representation. And what we have here are 8th grade, 10th grade, and 12th graders and the past year prevalence. I chose cocaine for this particular graph, but we have it for all of the other drugs as well. And from my perspective as a researcher and as a person with a background working with patients, the first thing that comes to mind, of course, is that we shouldn't see any cocaine use in this population, and yet here it is. And we can see even as young as the 8th grade, we're seeing levels of use that are quite measurable and quite significant. One of the questions we're often asked is why in some countries we even see higher among 8th grade than in the 12th grade. There are a lot of reasons why this might be happening, in part because students that begin using drugs and such serious drugs at that level may not in fact be making it all the way through high school, but that's a slightly different conversation to have. But it's still something that we, it's important to recognize that we are seeing serious drugs abuse in very young people. One of the other issues we see when we discuss early use are your high risk behaviors. As an example here, I have put the percentage of secondary school students who engaged in binge drinking. Now, this is out of a proportion of the students who reported having used alcohol in this past month. So we do have prevalence in general for past year and past month, your overall prevalence. What we're looking at here is within the students who already reported past month use, how many have also reported binge drinking within the 2 weeks before the survey. Binge drinking is defined as having consumed 5 or more drinks in a single event within the 2 weeks prior to the survey. And this is considered to be one of the higher risk behaviors associated with alcohol. Again, similar to my previous slide, we're talking about secondary school students here. So we really shouldn't be seeing any alcohol use in this population. Every country in the hemisphere, these children are already too young to be using alcohol legally. At the same time, we can see among kids who would qualify as regular users at least once a month, they are showing very high risk behaviors, even among that. And that, of course, brings to mind the issue that we often talk about, which is that some of it's the highest use or the highest risk populations that often have the most complicated behaviors. And these are things that we should take in mind when we plan our interventions and our policies. The next area that we wanted to call out for this report were use by sex, and in particular, we called them in the report changes in use, but in fact, these really aren't changes. These are really just issues that we hadn't drawn attention to in the past. But one of the things that often is part of the conversation in Latin America and the Caribbean is this perception of drug use as a male phenomenon. But in fact, our data is showing that there are certain drugs that are used at the same or higher rates than males. There's a lot of alcohol use that is nearly equal among males and females, and even higher among females in some countries. In this particular slide, I want to draw attention to tranquilizer use. So benzodiazepines are one of the tranquilizers that we would have in this category. And what we see is that the misuse of tranquilizer pharmaceuticals is higher among females in every single country, or nearly every country, and in every population that we study. So general population, secondary school students, and university students, every one of these populations in each country shows higher proportions of use among women than men. Why is this important? Why is this important for policy? Well, first of all, pharmaceutical use often doesn't fall under drug use policy in some countries, or even if it does, it's not always considered a problem. And yet what we have here are young women and who are reporting tranquilizer use, and the question is indeed specific, that this is non-medical use. So they're misusing tranquilizers at much higher rates, and it could in fact indicate in some countries that there are substance use problems that aren't even being recognized as a problem. If we were to break down what that use looks like in a graphic form in each of these countries, what I have here, graph 7.8, this is among university students, graph 7.7 is secondary school students, and graph 7.3 is the general population. And every single one of these, we're seeing more use among women than men. And this brings us to the issue of what are the challenges we see for drug policy in our region as a whole. The first one I have here is actually NPS, but I want to begin with the pharmaceuticals themselves, because that's what we were just talking about, is that challenge that the pharmaceutical use are not necessarily considered a drug problem in the first place. And so we have to think about how we consider our policies, how we design our policies. We're seeing more and more new psychoactive substances, NPS. We are seeing opioids, and within the rubric of tranquilizers, the benzodiazepines are in fact the most common ones we see used in the region. These present particular challenges for treatment and in public health in general. Part of that is because we already know from our neighbors in North America and Canada that they're experiencing serious epidemics of opioids and NPS, and have some of the highest overdose rates in the history of drug use. And one of the issues with the opioids and NPS is this crossover between what is a pharmaceutical, what is a legitimately used pharmaceutical, one that is misused or deviated from the market, and also ones that are in fact clandestinely developed and are in fact NPS, such as your synthetic fentanyls. Now, we are not seeing high rates of synthetic opioid use in Latin America or the Caribbean. We do know that there is a presence. That presence we can confirm through the early warning systems in the countries that have them. So we do know that there is fentanyl in South America. We're not able to quantify the amount, but we know that it's there. And we know from some qualitative research studies that, that we've done that there is opioid misuse, probably mostly deviated from the legitimate market, but it's not yet confirmed. But we know that it is there, and we know that this has been, has caused a major issue in North America. And at the same time, we have a lot of countries that are struggling with access to opioids for legitimate medical use, and that presents a very complicated situation when it comes to developing policies. Other challenges we see have to do with the high-risk behaviors I mentioned previously, such as alcohol, early use, the binge drinking behaviors that we see are very common across the region. And one of the other challenges that we also see are the changes in legal and regulatory status, particularly of marijuana. They continue to evolve. In fact, this morning I got a text about an official change in Barbados. There's more decriminalization of marijuana for medicinal purposes. That increases access. The data on how that might impact younger people is somewhat disputed, whether or not it increases or decreases use. There's not a lot of evidence that that there will be a big increase in younger people. At the same time, we don't really know what long-term impact of marijuana use will have on people's health. And so, some of these questions just remain to be seen, but they should be monitored. And in closing, I just wanted to touch on the issue of substance use in the COVID-19 context. In general, we don't know what the impacts are. There's different data that's come from different countries. Impacts have been shown in different directions. Some countries have seen increases in substance use, particularly alcohol. And others, there have been no change, and others, there's been decreases, probably because of access issues. And not alcohol alone, but also other drugs. One of the things that we were discussing a lot within CICAD when the COVID sequestration began and we had to start staying at home was, how that would change behaviors. But I think from the demand reduction side, particularly the mental health side, what's important to keep in mind is that COVID presents a stressor, and it's a stressor that really has a domino effect. So the more time that we are staying home, that that doesn't only impact our own mental health and our family dynamics and our work dynamics, but it also impacts our ability to manage our jobs, and our economies overall. And the long-term impact on our national economies is a big issue that, again, we don't know how long that's going to be or how long it's going to stay with us. And so what we're probably going to be dealing with are accumulation of stressors that are going to continue to have impact over time. So my concern and something that I think is worthy of us really monitoring, it's not just the impact that we have today during COVID, it's how the experience of COVID and how we've dealt with that is going to be impacting us over time. This is something that even when the COVID crisis itself is gone, is going to be having accumulated effects on our populations. And a lot of those will be in issues that will result in anxiety and mental health issues, economic issues. There will be more stress upon middle and lower classes. So there are many different things that will be affecting our most vulnerable populations, and they're not going to stop just when we're able to go out of the house again. They're going to continue over time, and we need to be thinking about that. From my side, I think about it in terms of monitoring, but we also have to think about it in terms of how we're going to manage mental health in our populations over time. So that is the end of my presentation. I hope that it was compact enough, and thank you again for allowing me to participate in this event.
Thank you very much, Marya. And again, thank you very much for providing that summary of CICAD's work and in the Americas. And as you said, like the protocols, the observatories, and also the data that you're collecting on drug use and providing us with that. So thank you very much. And again, I would like to thank everyone, our esteemed panelists and opening ceremony speakers. We understand that we have definitely run over. So what we are going to do is we will actually not do the Q&A session this week. So if you have any questions, we will then try for next week to answer them. And we have a list of questions compiled so we can ask the panelists, and we will get back to all of you next week. So I hope that you can join us next week. Thank you all for participating in this first virtual plenary session. There was a lot of information, great updates on drug demand reduction in Africa and also in the Americas. It was really exciting for us to see that so many people joined us from all over the world. We had, looking at the registration data, we had people from over 100 countries registered and people from 34 African countries. I was going to read the list and mention all the African countries, but because we're really running out of time, I will do that next week. So thank you very, very much. And also we have received many thank you notes and congratulations from around the world. Thank you very much. We really do appreciate that. And thank you for all your support. I would like to invite you all to our next conference session, the second one, which will take place next Tuesday on September the 22nd at the same time, 2 p.m. South Africa time. That session will focus on evidence-based prevention, covering the global prevention standards that Giovanna and Chloé mentioned today. We will be talking about media-based prevention programs and alcohol use prevention. I would also like to again remind you and invite you to help us spread the word and invite your colleagues and friends to become ISSUP members so that they can also join our global community of prevention, treatment, and recovery support professionals. I thank you all again and would like to encourage you to keep going, to keep making a difference in your communities. And I hope to see you again next week. Thank you all and stay safe.